presentation?
The second presentation.
Is that 20?
Yes.
Okay.
More long-term outcome. So the presenter is Kedar Alizai. It's Q. R-C-A-F-R. And yes, I'm sorry. Kedar Alizai.
Same institutions?
Yes, and he is on the manuscript that is submitted.
Okay.
Yeah.
You guys got-
Yes.
Okay.
Thank you for
And just, yeah, you can have this seat. Okay.
It's 5+3.
Yeah, you're fine.
Our excellent presenters here. And yesterday. They were back. So identified. Good. Fortified with coffee, and then you're ready to start our Quickshot Session 3.
Yes, as a speaker, do you push it back into your?
If you just touch that, if you just tap that, is there a red light? No, I don't have a red light.
I do. It's right here. Good morning. Can you hear me? Yeah.
Yeah, you can introduce yourself real quickly. Introduce yourself.
Yeah.
I introduce myself. You introduce yourself.
Yeah. Good morning, everyone. Thanks for making it to this early morning session. My name is Elliot Asari. I'm a surgical oncologist at the University of Utah in Salt Lake City. My co-moderator.
Juan Santamaria, surgical oncologist at the University of Nebraska in Omaha. Thank you for coming this early morning. Hopefully you're getting coffee so we can get started with the first speaker, who is going to be Hunter Moore from the University of Colorado. Is going to talk about early predictors of prolonged intensive care utilization following liver transplantation.
All right. I'd like to thank Southwest Surgical Association for the opportunity to present our group's work. Here are disclosures. So ERAS has been adopted in multiple surgical specialties and has really become the standard of care for getting people in and out of the hospital quickly. Not surprisingly, liver transplant adopted it early. And with early extubation, a lot of people that almost universally went to the ICU were able to go to the surgical ward. Over the past 20 years, we've been able to drop that rate down to about 50%. But with the evolution of ERAS, everyone has this anticipation of people are going to have a short stay and quickly get in and out, but liver transplant is still a major abdominal operation. And we often get this question the first day these liver transplant patients are in the ICU of how long is this patient going to be here, which seems kind of crazy, even though they're hooked up to a ventilator on dialysis, but we get it all the time. So we wanted to evaluate the labs on post-op day one to see if there's any potential to give us a prognostic ability to more confidently tell patients and family members how long their patient might be in the ICU. Looking at numerous other scores for ICU prognosis, such as Apache, Denver, Marshall, or SOFA score, we thought that bilirubin, creatinine, and probably some additional liver function tests might predict if a patient would have prolonged ICU stay. So we have a prospective observational cohort of coagulation and clinical labs. We looked at these preoperatively and through postoperative day one. We define prolonged ICU as admitted to the ICU in there for 7 days because that's kind of the call block that an intensive care unit team would have. We started by looking at labs that correlated with ICU-free days, and then looked at the ones of interest and see if they correlated to prolonged ICU using a rock curve and found the inflection point for them. And then we used a multivariable regression analysis to control for other confounders that could be associated with prolonged ICU stay. We had 304 patients included in the analysis. Median age is 55. They're relatively sick with a median MELD of 23. Majority had brain dead donors. And as consistent with our other data, about half the patients went to ICU and only 15% had this prolonged ICU stay. We look at results. This is the myriad of different post-op day 1's labs that were available, and 2 popped up that were significant in our rock curve. First was our creatinine. We found an inflection point of greater than 2.6 on post-op day 1 was associated with prolonged ICU stay. And our third one was using a modified TAG assay where we had TPA to it to quantify how resistant you are to fibrinolysis. And if you had no lysis when you had TPA to your TAG, this is also a risk factor for prolonged ICU use. When we look at the distribution of the risk factors of elevated creatinine in prolonged ICU stay, 15% had both. About a third had just fibrinolysis resistance, and then there's about 10% that had just elevated creatinine, with almost half the people having none of these risk factors. When we look at our distribution of prolonged ICU stay, you can see that if you have no risk factors or both risk factors, your risk went from about 4% to greater than 60%. When we controlled for all the risk factors associated with prolonged ICU, we see that both elevated creatinine and fibrinolysis resistance persist as independent risk factors for prolonged ICU stay. Then when we looked at ICU-free days, looking at those people that were specifically admitted to the ICU, if you had both fibrinolysis resistance and elevated creatinine, you can see on that dark line on top that you had more time in the ICU. And almost 20% of these people were still in the ICU about a month after their admission. We also found some other more hard outcomes. The 90-day graft survival was significantly elevated in this group. If you have both risk factors, you actually had a 20% risk of losing your graft in the first 90 days, which is really elevated. And the other thing that we identified that might be a little mechanistic is that those people that had fibrinolysis resistance and elevated creatinine had a 46% rate of remaining on dialysis at a week after their admission to the ICU versus only 11% that regained fibrinolysis, hinting at maybe a mechanism that fibrinolysis might help recover with multiple organ failure. So in summary, post-op day 1 liver function tests actually are not helpful at all at predicting prognosis and the length of stay in the ICU. Elevated creatinine can by itself predict if people are going to be in the ICU for a long period of time, but that combination of both fibrinolysis resistance and elevated creatinine not only give you a 60% chance of being in the ICU after a week, but a 1 in 5 chance of losing your graft in 90 days. And we're beginning to question the role of fibrinolysis in recovery after transplant. Thanks for everyone's time, and I'm happy to answer some questions.
Morning, Krista Couch, Fresno, California. I'm looking at things from the ICU perspective and, intriguing, tantalizing data. The question I had, and maybe I missed it when you presented, is how did you account for, because not every patient starts from the same level of creatinine pre-op. People have different levels. How did you account for people who had maybe normal or mildly elevated creatinine before, was there a role for looking at the delta for the individual patient? I hope that makes sense.
Yeah, totally makes sense. So when we did the univariate regression to look for confounders, creatinine, sodium, bilirubin, all that came up, and that all goes into your MELD score, which is also significantly different between the groups. So when we did our regression, we controlled for the preoperative sodium or the preoperative creatinine to adjust for that.
Okay. And the other question is, because not everyone's using fibrinolysis resistance, is there anything else for people who are in places that aren't, that might be another, not quite as strong, but probably a possible thing to use? I mean, you're obviously trying to keep it as simple as possible. So the third strongest predictor.
Yeah. So when we did our breakdown of the different variables that were associated with, there's a different myriad of variables that are associated with ICU free days, not necessarily like 7 days in the ICU, but a longer duration. Other things that came up were your bilirubin, your INR, and your albumin were all things that were associated with it. So there's different variables you could play with, but creatinine is so strong. If you looked at the C statistic of that model, it was like 0.83 or something like that. So creatinine on its own, you can actually just use, and kind of in the manuscript, we discussed that, hey, you could just use creatinine. This fibrinolysis resistance is just kind of like a little bonus on top, but it's pretty crazy. If your creatinine is elevated that high post-op day one, you can just tell that you're in for a bad recovery.
In for a long road,
Yeah.
a long bumpy ride. Thank you.
Did y'all consider using NephroCheck, or do you use that in your institution, like for early creatinine, early kidney injury determinant? It's a metalloproteinase.
Yeah,
lab test.
that's a good question. The company actually just asked us about trying to test it out. I heard it's pretty accurate. It's kind of interesting. Almost like, I think it's like 80% of liver transplant patients will have some type of AKI. The severity isn't even as bad on post-op day one. So people tend to nadir about post-op day 3 with like their worst renal function, but something like that could give you that early prognostic and not wait until your terminal creatinine, or not your terminal, but your nadir creatinine.
Yeah. And then my second question was, are there any predictors, or first, what are the mechanisms, and are there any predictors of fibrinolysis resistance?
Yeah, so the mechanism you're saying in terms of the fibrinolysis resistance and potential organ recovery, we have some data that shows that you actually put clots in your organs all over the place. Definitely in the liver that we have biopsies, we can show that. And in the beginning, the clot actually appears to be protective. And so the longer duration that you have that clot in there, perhaps you're getting lack of perfusion. It also is a site that activates neutrophils and recruits inflammation. So you might have this persistent inflammatory state if you don't clear this fibrin that originally seems to get laid down for a protective effect.
So it's clear that fibrinolysis helps, but we don't know why some people have problems or have a resistance to it.
Yeah, I mean, the lab's working on a mechanism for it. We actually found this like beta-2 integrin that seems to recruit neutrophils that are pro-fibrinolytic. So that could be the mechanism. We're still working on it, but that's what we think is doing.
Thank you.
Thank you, Dr. Moore. Excellent presentation. Next up is Dr. Kaider Alizai from University of Arizona to present on the long-term outcomes of non-operative versus operative management of pancreatic injuries. Should we really never mess with the pancreas?
Good morning, everyone, and thank you for providing me the opportunity to present our study. I have nothing to disclose. Pancreatic injuries are rare injuries accounting for only 0.2 to 12% of all abdominal traumas. Yet they are challenging to treat and may result in significant morbidity and high mortality. There have been multiple studies on the early outcomes of pancreatic injuries, both managed operatively and those managed non-operatively. However, there is limited data on the post-discharge outcomes of these injuries on a large scale. We aim to compare the 90-day outcomes of pancreatic injuries patients managed operatively versus those managed non-operatively, and hypothesized that operative management might be associated with worse outcomes in these patients. A retrospective analysis was conducted on the nationwide readmission database 2017, including all the adult trauma patients with pancreatic injuries, while excluding those who died during index admission and those with inaccurate or missing information. We stratified the study cohort into non-operative group and the operative group, and looked for the outcomes, including 90-day mortality, readmissions, complications, the need for endoscopic or percutaneous drainage. Not mentioned here were the length of stay and other complications as well. Several statistical tests were performed for comparison. 1,500 patients met the inclusion criteria, out of which 461 underwent operative management and 1,092 underwent non-operative management. Looking at the baseline characteristics, the two groups were significantly different in terms of age distribution and gender, yet there were no differences in terms of other baseline characteristics and comorbid conditions between the two groups. Looking at the injury characteristics, The two groups had significant differences in general and pancreatic injury characteristics. Interestingly, the non-operative group had higher severity of injury and abdominal AIS, whereas penetrating injuries, pancreatic tail, and pancreatic body injuries were more likely to undergo operative management. Concurrent non-pancreatic injuries were also more likely to undergo operative treatment. On univariate analysis for outcomes, operative management was associated with significantly longer hospital length of stay and higher rates of unplanned readmissions within 90 days of discharge. This group was also associated with higher rates of intra-abdominal abscesses, pancreatic insufficiency, and endoscopic or percutaneous drainage within 90 days of discharge. On multivariable regression analysis, while controlling for the potential confounding factors, we found that operative management was an independent predictor of longer hospital length of stay and higher rates of readmissions, intra-abdominal abscesses, pancreatic pseudosis, and endoscopic or percutaneous drainage within 90 days of discharge. In summary, operative management of pancreatic injuries is associated with longer hospital length of stay and higher rates of 90-day complications and hospital readmissions. In conclusion, non-operative management may be superior to operative treatment in select patients, and those treated operatively are at increased need for surveillance even after discharge. I would like to thank my mentor, Dr. Bilal Joseph, and the Division of Trauma at University of Arizona for their constant support, and I'll be open to any questions. Thank you.
Open the paper to questions. Yeah. If none, do you have questions, Dr. Hazan?
Yeah. So Dr. Alizai, great presentation. In terms of looking at those with concomitant intra-abdominal injuries, right? I mean, how do we explain that the readmissions and the sepsis is not due to possibly the colectomy that they had, but rather due to the pancreas injury?
That's a great question. So we actually looked at the complications overall and readmissions overall. So we cannot really differentiate what the readmission was for on our database. However, looking at the complications, since we specifically looked at the pancreatic complications like intra-abdominal abscesses and the pancreatic pseudosis, pancreatic insufficiency, so we can at least identify that these readmissions were more likely due to these complications.
Thank you.
Yeah, interesting paper and interesting database. I didn't know the existence of the nationwide readmission database. So my question is related to the severity of the pancreas injury. And by looking at the slides that you presented, I don't think it was in the abstract, it seems that the patients who went operative management had higher pancreatic injury grades. So how do you resolve the confounding that perhaps they have higher morbidity because they have a higher injury to the pancreas that then pushes the surgeons to do an intervention to the pancreas or other intervention in the abdomen? So how do you control for that confounding factor? I think it's in the same nature of your question, Dr. Asari, and maybe you can't with this database, but would it be possible to do this analysis by adjusting the pancreatic severity scale?
So one of the limitations of our database is that this database does not provide the AAST grading of pancreatic injuries, but we did try to control for the general injury severity and the abdominal injury severity. So even after controlling for that, we found that operative management was associated with significantly worse outcomes. Other than that, that's unfortunate. We cannot go into the details of the grading because of the limitation of database itself.
Right. Thank you. And I have another question, unless someone else in the audience does. In terms of, do you notice any variation in terms of regional variations or hospital type? Did you notice did that have any effect on operative versus non-operative approach?
There was basically no difference in terms of the effect of teaching hospital status or the size of the hospital based on the number of beds.
Thank you.
Thank you. Thank you again.
Thank you. For the next presentation, we have Krishna Manohar from Indiana University, who will be talking about brain-gut crosstalk murine model of necrotizing enterocolitis activates brain microbiome. Thank you.
All right, thank you for the opportunity to present. These are my disclosures. Necrotizing enterocolitis, or NEC, is a devastating condition that primarily affects premature infants and their intestines. They often, if they survive, contend with several long-term complications, such as neurodevelopmental impairment. The gut-brain axis is implicated in this disease process, and the theory is that intestinal injury leads to long-term neuronal injury, and the complex interplay between the microbiome, the enteric nervous system, and other signaling pathways are implicated in this disease process. Mesenchymal stem cells are emerging as a therapy of interest in this treatment of this disease. And our lab has shown that prophylactic administration of mesenchymal stem cells in the peritoneal cavity of these mice results in improvement of NEC outcomes. So knowing that infants with NEC have long-term neurodevelopmental impairment, we wanted to see in our murine model of NEC if mice also show inflammatory changes in the brain via activation of microglia, which are immune cells of the brain. So to do this, we employed our standard NEC model. We exposed 5-day-old mouse pups to hyperosmolar feeds, intermittent hypoxia and hypothermia, and compared them to breastfed controls. They were assessed daily for clinical sickness scores, intestinal perfusion, and weight gain. And on postnatal day 9, animals were euthanized and their intestines and brains were explanted for further study. We also wanted to look at stem cell treatment further, and specifically on rescue therapy of stem cell treatment. So these mice were then subjected to an intraperitoneal injection of stem cells on day 3 of the model to see if they had improved intestinal and brain outcomes. And here are our results. The bars on the left are breastfed controls. The bars on the middle of the pink are our NEC model with PBS, which was just our vehicle control. And the green bars on the right are our NEC model with our stem cell therapy. And as you can see, we have our NEC shows consistently worse outcomes with decreased weight gain, worsened clinical sickness scores, and worsened macroscopic and intestinal histology scores. And our rescue therapy with an intraperitoneal injection of stem cells shows improved clinical sickness scores and better macroscopic and intestinal histology scores. So let's dive into that a little further. Sorry for the images. We have our breastfed control shown first. And when we look at our NEC, we see that there's frank pneumatosis or air lining the bowel wall. And we see dilated loops of bowel throughout. In our stem cell therapy group, we see significant improvement in the pneumatosis and we just see almost no bowel wall dilation. Now looking at the intestinal histology, on the left, we see our normal breastfed controls with retainment of the basement membrane and normal villus architecture. In our NEC group, we see frank disruption of that architecture in the basement membrane. And in our stem cell therapy group, we see a retainment of that basement membrane architecture and protection of that villus structure, that normal one. We also looked at the cytokine profile of our intestines, and we see that IL-10 is an anti-inflammatory cytokine, and in our NEC groups, we see a significant decrease compared to our breastfed controls, but no significant change with our stem cell therapy. However, when we look at the pro-inflammatory Th17 pathway, we see that there's a significant increase in 3 significant cytokines, IL-6, TNF-alpha, and IL-17A, in our NEC model, and that when treated with stem cells, that there's a significant decrease in all 3 of these pro-inflammatory cytokines, showing that NEC results in a decrease in anti-inflammatory signaling and an increase in inflammatory signaling, but our rescue therapy with stem cells was able to decrease significantly that inflammatory signaling from the intestine. And now to look at the brain. So we specifically looked at microglia, which are immune cells of the brain. And resting microglia are characterized by increased branching and increased spread. They act as sentinel cells in the kind of immune environment. When they're activated, they become more amoeboid in shape with minimal branching and decreased spread, and then go on to act in the local environment to cause injury. The above graphs are measures of branching, and the graphs on the bottom are measures of spread. Overall, our pink shows decreased branching and decreased spread throughout, showing that NEC has an increase in microglial activation. When treated with stem cells, we show recovery of that branching, and we show a recovery of the spread, showing that stem cell therapy attenuates the microglial activation that we see in the brain. We also have preliminary results looking at oligodendrocytes, which are the myelinating cells of the brain. And we see that in our neck, we have a decrease in myelinating oligodendrocytes. And in our stem cell therapy group, we have a recovery of that myelinating population. So in conclusion, our data shows that our gut-brain axis is implicated in the disease of of the neck model. We show that neck results in intestinal injury and an increase in pro-inflammatory cytokine release, which results in microglial activation and a decrease in myelinating oligodendrocytes. And we show that rescue therapy with stem cells results in decreased intestinal injury, decreased pro-inflammatory cytokines, and a decrease of the microglial activation in the brain and a recovery of those myelinating oligodendrocytes. And just to skip ahead, but thank you for your time, and I'll take further questions.
Interesting model done in 5-day-old pups. They must be very tiny and difficult to gavage. My main question is with the methodology and the model of neck that has probably been described before, but so could there be the use of an additional control because these pups are getting gavage feedings, hypoxia, and hypothermia? How can you discard that the changes in the brain microglia and oligodendrocytes are not due to the hypoxia and or hypothermia? So there should be perhaps a control that is breastfed while getting hypothermia and hypoxia to see if those changes. Is that something you guys have considered with the model?
So we have considered that. We've done looking at the brain as a new addition to the experimental model, but we have compared our results to formula-fed controls where they undergo the same experimental model, but the formula just doesn't have LPS in it. The intestinal injury is more comparable to the breastfed controls. Their weight gain is the only thing that's significantly affected. Similar with their cytokine profile is similar to the breastfed controls. So we will look at the brain in the formula feds as well, just to make sure that we don't see that activation, but the intestinal injury is not there.
And perhaps the brain also on the breastfed pups that undergo hypothermia and hypoxia. That would be a criticism also. Yeah, but very nice model and very provocative findings with the stem cells. Where did the stem cells come from? What is the reagent from? Or
they're umbilical cord derived.
Umbilical cord divide, stem cells, yes. Human stem cells.
Couch had a question. Yeah.
No, I was just gonna, if you actually sort of anticipated my question, I was going to ask, where do you go next for this model?
To also answer that, one of the other things that we're looking at is the long-term impairment. So we've seen short-term changes in the microglia and other cells in the brain, but we're letting these mice grow out into 2 months old to look at kind of long-term behavioral findings in motor, cognition, and social behavior. And if those are also what we expect, then to see if the stem cell therapy improves those long-term outcomes.
Dr. Monahan, I have one question. Great presentation. Is there like an optimal timing for intervention? So when there's neck, have you noticed there is perhaps 3 days, 4 days, 5 days before the microglia get activated, and therefore you can intervene at a certain time point to have maximal effect?
So we haven't looked at that specifically. Instead of a dose response, more of a time response, I guess, curve would be a really good thing to look at. We wanted to see if, because a lot of times with NEC, we never really do prophylactic therapy with stem cells, but we just wanted to prove that stem cells work. So this was the first time we ever did a rescue therapy that's been published so far, showing that even halfway through the model of disease that you can have significant effects. So we'll start to look at the optimal timing as well. Thank you for that question.
Thank you.
And one last question. What is your hypothesis or your explanation of why you think the stem cells are working mechanistically in the you're injecting an intraperitoneal and 5-6-day-old pups. So how is that, how is that working?
So far, the studies in our lab have indicated it's likely a paracrine mechanism. And so that's one of the reasons we're looking at specifically the immunomodulation of that Th17 cell profile. And so we've shown that there's changes in the cytokine profile of the intestine. We also have data in our lab that's showing there's improvement with basically lungs and also brain. So there's a paracrine mechanism even with local kind of changes that go on.
Thank you. Good job.
Yep.
Thank you. Next, we have Dr. Ortega from Texas Tech to present on robotic cytoreduction and HIPEC for appendiceal and gastric cancers.
Dr. Constantinidis is filling in.
I'm not Joanna, but
That's right.
this is actually coming this afternoon to present another paper tomorrow. So you're going to have the pleasure of seeing her. This is actually a video, so we can start playing, please. It's narrated.
We're going to present robotic cytoreduction and HIPEC for appendiceal and gastric cancers video illustrated. It's a work from Texas Tech in El Paso. Our patient is a 40-year-old female with history of signaling cell gastric adenocarcinoma, status post-total gastrectomy, then recurrence 2.5 years later with response to chemotherapy. Radiologically, no evidence of disease, and a 49-year-old female with localized mucinous appendiceal neoplasm. This is our port configuration. We typically start with 4 robotic ports at the level of the umbilicus and cytoreduce the disease from the upper abdomen, then redock and do the same for the lower abdomen. We use a 12 millimeter assist port, which later is used as an outflow for the perfusion part and an symmetrical inflow in the right upper quadrant. Starting with the gastric adenocarcinoma case, the right upper quadrant is being examined and any suspicious areas are quickly and easily resected with the use of the robotic shears. The gallbladder is being reflected and tumor nodules are discovered, and robotic cholecystectomy with the use of icy green is being performed. Critical view of safety is being established, and with the use of icy green, we verify the anatomy. This technology is also particularly useful for discovery of any ducts of Luska during the dissection of the gallbladder. A large nodule is found at the falciform ligament, which is easily excised with the use of the robotic shears. Taking down the falciform ligament facilitates also the later placement of the perfusion catheters. The rest of the upper abdomen is carefully examined. Any suspicious areas are resected with the use of the robotic shears. Omentectomy is being performed with the use of a vessel sealer. In this step, we are especially careful to avoid any thermal injury to the colon. Once we completely cytoreduce the disease from the upper abdomen, we redock and turn our attention to the lower abdomen. Multiple tumor nodules were found in the terminal ileum. All of these are being carefully resected. This is one of the utilities of the robotic surgery with the shears and articulating instruments. Is very easy to resect those nodules and repair the bowel as needed.
Can you fast forward towards the end? It's a longer video, unfortunately, from 5 minutes. Okay, so the second case, we pretty much do the omentectomy, cholecystectomy. That necessitated actually a resection of the terminal ileum for disease and then ileocolonic anastomosis. And we saw a little bit the assessment of the bowel perfusion with the icy green and the intracorporeal anastomosis. And pretty much after we're done with the cytoreduction, we place our perfusion catheters through the assistant port in another incision on the right upper quadrant, and we do the perfusion. And of course, the anastomosis after the perfusion. And pretty much both patients recovered bowel function on day 3, and they were discharged on day 6 uncomplicated with peritoneal carcinomatosis index 5 and 6. And they're doing very well after 6 and 8 months of follow-up. Obviously, these are highly selected patients with low carcinomatosis index. You cannot really do the really jelly belly that the whole abdomen is taken by mucin, okay?
Yes, thank you. That was going to be my question for you about patient selection. I know the PCI was obviously low. Were there any other factors you looked at before selecting these patients for this robotic?
It's a very good question. So when we make discussion in the clinic, I tell to the patients there is always a chance we may do your operation open, but pretty much we don't have an anatomical constraint. It's mainly how much disease it's in each quadrant rather than which quadrant is involved. You can mobilize the right lobe of the liver and find if it is a small amount of disease over the right diaphragm, you can cytoreduce it robotically. Now, the existing literature is mainly laparoscopic hypex and mainly ovarian, but I think we're going to start seeing a shift to that, and we're going to see more and more robotic because of the technical advantage over simple laparoscopy. And I think one of the benefits of this technology is why we don't do many clinical trials on HIPEC. For example, we did the Prodigy 7 trial on colon cancer. Everybody said, okay, HIPEC has higher morbidity. We stopped doing trials. But if you take the low carcinomatosis index disease and you take away the morbidity with a minimal invasive technology, then people are going to be more willing to do more and more trials to find the right regimen for these people.
Good point.
Yeah, good point. A very valiant effort with the young woman at 40 with the signet rail, signet cell, that minimally responsive to the initial chemo, but then appears to have been stabilized with chemoimmunotherapy. So yeah, as you say, most of the data of a HIPEC, minimum invasive HIPEC is laparoscopic. Any robotic HIPEC data that you're aware of or experiences that are being published or reported?
There are a few case reports, probably 4 or 5 case reports out there. Yeah, actually, this patient, the medical oncology pushed me harder than myself to do it because they started her on a neoadjuvant and her CA dropped, and the medical oncologist was, "Can you try to reduce the disease?" I said, "That's technically easy. We can do it. I don't know exactly what is the benefit." And that's why we need to learn more about these patients to find the right perfusion agents for those, and the duration, of course.
Yeah, I think there was a recent experience from MD Anderson and an NIH paper at Annals of Surgical Oncology, in which they did see a HIPEC for gastric cancer. And at MD Anderson, I think they do a laparoscopic HIPEC, I think kind of before, and then later they do an open cytoreduction, or and their overall mortality was still poor, like 20% 5 years. But
that's actually some of the data that tells you that it works, but we don't know exactly how we have to approach these patients. Dr. Badswell's data from MD Anderson, so he takes mostly people with positive peritoneal washings, but he has shown that a significant proportion of these patients, if you keep treating them with HIPEC, they're going to switch, they're going to turn the washings negative. So actually it works. And he does it every couple of months, I think, until he does 4 or 5 of them. And if they don't switch, then he stops. But he has shown that a significant proportion of patients, they're going to actually respond to that. So more to come on this.
Yeah, and as you know, Turaga, they've spoken about this iterative HIPEC, and so I think this is another modality for us to be able to do multiple hypec sessions, right? in a
Exactly.
Minimally invasive approach, as opposed to doing a big open laparotomy every time you want to do that. So that's
Exactly.
last question for you would be, port site seating, what
Oh, yeah.
approach do you take to try to minimize? Because, some of these patients over time, they're going to develop disease at a port site if we're not careful.
Yeah. Well, I might be able to answer this question in a few years because now we're just starting. But we'll see. Gastric cancer, yeah, it can give you this problem. Yeah. Now realize some people they're doing now the pipec, the pressurized intraperitoneal. Some others they put ports for gastric and they give sessions of intraperitoneal therapy. The big benefit of doing it surgically is that you actually get tissue. And more people experiment on this tissue to look for cancer cells, to look not only to look for cancer DNA. So it's to me, it has the benefit of getting the tissue. Also, you can understand better the clonality of the tissue and the resistance to therapy. Yeah.
All right. Thank you, Dr. Constantinidis. Okay. For the next paper, we have Conor McDaniel from the Methodist Dallas Medical Center. Is that correct? Yeah, we will be talking about an Neptune waste management system used with atrium chest drains. Is it dangerous? Question mark. Thank you.
Excuse me. Yeah, I'm Conor McDaniel. Thank you for the opportunity to present. Do I advance with here? All right, we have no disclosures. So there's a lot of background for this, but the Neptune waste management system is an operative waste management system that disposes of undesired bodily fluid in the OR. It has variable levels of vacuum suction. In 2015, the Neptune was recalled following a lawsuit that involved a patient death. And in this lawsuit, suction was connected directly to the patient's chest tube without a chest drainage system. And unfortunately, the patient suffered a fatal event following this. Following this lawsuit, the manufacturer advised against usage with chest tubes, and many institutions prohibited Neptune use with chest tubes or with chest tube drainage systems. However, in the case that chest drainage system was not used, and most chest drainage systems have mechanisms to ensure a set level of suction is delivered to the patient. So we tested these mechanisms against variable levels of Neptune suction. So there's several different types of chest drainage systems, and the suction control mechanism can be different. Sometimes it's a wet system that's controlled by water, and sometimes it's a dry plastic system. At our institution, we use the atrium chest drains pictured below. When you're using a wet drainage system, gentle bubbling is expected. However, violent bubbling indicates that there's excessive suction, and this increases fluid evaporation and changes the suction over time. So for our study, we assembled both of these according to manufacturer specifications. We set them to the standard -20 centimeters of water of negative pressure. We then zeroed and calibrated a pressure transducer on the chest tube attachment site of the drainage system. We then applied varying levels of suction from the Neptune and from regular wall suction, including low, medium, high, and maximum wall suction. So on maximum wall suction, the mean pressure was -9 delivered to the patient. This is for the dry section Oasis atrium system. And on the Neptune, the mean pressure was -13, so slightly higher. These values were measured for 30 minutes and remained consistent over time. Neither type of suction met or exceeded the set value of -20 centimeters of water, which was surprising. We expected that they would at least reach the -20. The wet suction devices more accurately controlled the delivered negative pressure. The maximum regular wall suction delivered a consistent -24 centimeters of water. The measured pressure on the wall regulator was -500 centimeters of water, and there was violent bubbling in the suction control chamber as expected. And here's the results for wet suction with the Neptune at varying levels of Neptune suction. So at 45, -45 centimeters of water on the Neptune, the reading at the patient was -21. These slightly increased with increasing levels of suction with maximum at -403 centimeters of water, delivering about -26 centimeters of water to the patient. And there was also violent bubbling on maximum Neptune. And we also noticed when the suction tubing was abruptly disconnected and reconnected, that we had a transient peak negative pressure of -43 was observed. And there was some violent exchange of water between the two suction control chambers. So our conclusion is that the Neptune can safely be used with chest drainage systems. Dangerous levels of suction weren't examined even at maximum vacuum levels. And as with any chest drainage system, when you're using wet suction, you should use the minimum level of suction needed regardless of the device being used. And we suggest only using the level of suction necessary to achieve your desired result. Really, the Neptune is a tool like anything else in the operating room. It needs to be used appropriately. And I'll take any questions.
Thank you. Nicely done. We have a question here from the. That's okay.
Sorry, nicely done. And, it's been a controversial point and a big thing in the OR. So does that mean that you're going to use was this just proving that it could be done safely, or are you going to use that on your chest, the Neptune on your chest drains?
I personally think it's fine. I think convincing my institution that it's fine will be a different effort. But one thing where it's convenient as a trauma surgeon is you bring somebody up and to the operating room, and you don't want to wait time for them to bring another suction setup and hook each chest tube if you have 2 or 3, to a different suction system, whereas you have 8 canisters right there and readily available to hook up. So it saves some time.
Well, it's good because this had become dogma in the last several years. So thank you.
Yeah, I think we actually, our institution went to a different product and then they hooked it up, but it just doesn't say Neptune. It's still, and so thank you for proving that it is safe, because I'm like, it's the same thing. It's just a different
right
name.
And again, if you use the wall section on maximum and hooked that directly to a chest tube, you could hurt a patient using that as well. So
Exactly. Yeah. Well, thank you very much for your work.
Thank you.
No, yeah, definitely. Thank you for the presentation. One quick question. It's so to be very clear, do you recommend in your abstract or paper not using the Neptune at the max setting with a specific atrium, which is the ocean with the water column that is like super tall because of there's a lot of like
Violent
turbulence.
bubbling. Yeah, in any wet drainage system, you don't want violent bubbling. You want gentle bubbling, or the minimum required to achieve the desired result. Even with wall suction, even with the Neptune, you don't want to set it all the way to maximum if you're using a wet suction system.
Correct. Well, good luck at trying to convince the OR and the scrubs and the leadership of the hospital. Definitely, I've been there towards the later of my training, and I wanted to connect the chest tube immediately to the Neptune through the atrium, and I kind of, knew that it was safe. But thank you for proving it and putting it as a data there. But yeah, very well done.
Thank you. Next up is Dr. Wilson King from University of Colorado to present on factors impacting provider utilization of electronic health records, based pathways, variation across specialties.
Hey, everyone. I want to thank the committee. This place is unbelievable to be. So this is really an honor for me to be able to present my work and get to spend a few days here in Ojai, California. I have no disclosures. So quick background, clinical pathways are tools that use evidence-based practices and guidelines to create standardized patient care algorithms. The electronic health record pathways, they can aid clinicians in daily practice and then reduce unnecessary practice variation. EHR pathways can improve quality of care and increase patient and provider satisfaction. So one of the ways that we see this is there's been a lot of ERAS protocols that have been implemented. And with EHR pathways, you can go into the EHR, click the pathways tab, and then all your different surgical specialties, their ERAS pathways, their admission pathways can pop up, and it can aid residents, APPs, attendings in putting in the appropriate order sets. So the current state at our institution at the University of Colorado, as you see here, this is the usage of these Epic pathways. We use Epic at our institution. You see the residents are mostly driving this usage. It's only 2,700 users. and then physicians offer another about 300. However, when you compare that to the emergency medicine and hospital medicine groups, it's wildly more people, 129,000 physicians. There's been 129,000 different uses of this by EM, and then HM is less than that, but wildly more than the surgical providers. So our aim and hypothesis was to understand the specialty-specific barriers to using pathways, namely the surgeon-specific factors in order to improve utilization in the surgery department. Our methods were we sent out an anonymous email survey to emergency medicine providers, hospital medicine providers, and surgical providers. The questions in this series queried respondents on knowledge of clinical pathways, the knowledge of the existence of these pathways, the clinical applications in which they use these pathways, and then the perceived barriers to usage. We reported descriptive data from these survey resorts, and then it's a few group-wise comparisons using chi-square analysis. So our respondents, based on provider role, about 21% were trainees, 48% were attending physicians, and then 30% represented APPs, and 7% didn't report what their role was. 55% of these respondents to the survey reported greater than 5 years of clinical experience. And then 28% of these were hospital medicine, 34% were emergency medicine, and 36% were surgery providers. So this was pretty striking. This was just a table showing who knew about clinical pathways, that they even existed, that this was a tab in the Epic chart. Only 37% of surgery providers reported that they knew what these pathways were. Hospital medicine was 91%, and then emergency medicine was 79%. And if you compare these two, those are statistical significant finding. Now, granted, this graph is a little busy. What we're looking at is here, the y-axis is the percentage of respondents who check that they often or always have one of these barriers to using clinical pathways in the EHR. The yellow gray bar is surgery providers, EM is orange, and hospital is blue. And if you look across, I mean, what you see is just the surgery providers in almost every single category report a massively amount more perceived barriers to using these clinical pathways. The three highest, 54%, found it too difficult to find in the EHR, so they didn't use it. They had a lack of overall comfort using it in 65% of cases. And then a lack of knowledge about even the existence of pathway was also a very high percentage. But almost all of these were significantly different than their EM and hospital medicine counterparts. So in conclusion, although many surgery-specific pathways exist, ERAS is a great example of this. Surgery providers use these pathways less than hospital and EM providers. Surgery providers have many barriers to usage, including lack of knowledge of these pathways, lack of comfort using, and this was less than EM and HM providers reported. And then surgery providers may be hindered by inexperience in using these pathways, which should be addressed in order to improve implementation. So thanks for having me. I appreciate it.
Hi, Laura Brown from Peoria, Illinois. So I think this is a very timely presentation, and I want to thank you for doing it because at the moment, a lot of us are trying to develop more pathways for managing clinical diagnoses, small bowel obstruction, right upper quadrant pain, which apparently used to be called biliary disease, but now anything that's right upper quadrant pain is biliary disease until proven otherwise. So, I think this is really important. What do you think we need to do to overcome this barrier? Is this an issue of access to the list of pathways, just knowledge about them? What are your thoughts?
Yeah, so I think at our institution, at least, emergency medicine providers who are pretty big users of pathways at the university, during their intern orientation, they go through a session where they outline these pathways. They show you where the tab is. They show you how to navigate them and find the different algorithms and, et cetera. So I think surgery providers it'd be useful just to have a quick education. It wouldn't take long, 20 minutes, an hour, just to show you where these things are and to show some data on why it's useful. And I think people would use them. It'd make the lives of residents and APPs, I think, easier. All the orders are right there for you when you're clicking through them. And these are evidence-based, practice guidelines. And then also specifically to your practice, you can vary these and customize them, standardized to what your group wants to do. So I think it really just needs a quick 20-minute to an hour-long, orientation for interns, and then also current providers just need a quick education on it.
I agree with you. I think my concern is that all we need is one more piece of education to ignore.
Sure. Yeah.
When national president suggested that at the American Academic Surgical Congress this year suggested that we ignore these training sessions, the audience applauded very loudly. So I wonder if it would be possible to convince the EHR makers to instead develop a dashboard that comes up easy for us as you go to enter orders, as opposed to putting the onus on us to find them.
Right. I mean, that would be helpful. I mean, one of the surgery's biggest barriers was I can't find it or it's too hard to use. Yeah. So yeah, I think that's an excellent point.
Take your data, tell them, let's make it happen.
Excellent. Thank you so much.
Yeah. So have you considered expanding this survey to other institutions to see if it replicates in other institutions that may have better trainings or not? This is unique from University of Colorado, but
right.
What is your kind of gut tell you that this is also applicable overall in the country? Probably, maybe, yes, but.
Yeah, my gut tells me that most surgery providers, just based on talking to my colleagues at other institutions, don't use these. We have things posted in our workrooms that are the pathways on a Word document, but that's not super helpful. It's just sitting there. No one's even looking at them. So yeah, let's make it easier to find. Let's make it easier to use. And I think people will see some improvements.
Did you notice, I know you use surgical providers, but did you look at specialty versus subspecialty, and was there a difference?
No, we haven't. And that's something we are going to do, is try to further stratify it by, particular surgical specialties. I think others are more pathway oriented than some. So yeah, I think that'd be interesting to look at.
Great. Thank you.
Thanks.
Next, we have Dr. Benjamin Smith from Prisma Health. Comment to talk about negative pressure therapy in the management of esophageal injury.
Hey, thank you for having me. So we'll be talking about evac therapy in the management of esophageal injury and our experience at Prisma Health in Greenville, South Carolina. We have no disclosures. So esophageal injury is associated with very high morbidity and mortality. Historically, this has been managed surgically. The surgery is often fraught with issues with leak from this repair and high morbidity and mortality with the repair itself. Reconstruction options are limited as well, with not insignificant anastomotic leak rates. Other options are stents, clips, endoscopic suturing, which has been used by gastroenterology more so frequently, and endoluminal vacuum therapy. Here's a picture of a esophageal stent and over the scope clips often utilized by the GI. So more recently, endoluminal vacuums have been used for this purpose. The thought of their improved healing rates are decreased inflammatory phase reactants, reducing bacterial load, promoting angiogenesis and granulation tissue. This also helps control contamination and bring wound edges together. This is a picture of our endoluminal vac that we create at the bedside. It's just an NG tube with wound vac material sutured to the end. This was actually done in the ICU. So I just looked at all of our patients who we use this therapy on over the last year. This is our kind of early experience using this method. Primary endpoint being healing of the injury without additional surgery, and healing is confirmed with esophagram. Looking at the case breakdown, we have 7 cases that met this inclusion criteria over this course of time. A wide age range with 1 pediatric patient, 3 males and 4 females. Duration of therapy also is widely varying with 4 to 32 days. We look at number of sponges as far as looking at duration of therapy as well, because that's the number of times that either the sponge is placed or replaced. The average there is 4. We have healing rates around 86%, which is comparable to the literature, which reports around 70 to 100%. Different etiologies of our injuries also vary widely. There's extrinsic issues, iatrogenic, anastomotic, and a one Boerhaave patient. Location of our injuries also is the whole length of the esophagus, cervical to distal, as well as 2 different types of anastomotic leaks. Here's a picture of intra-abdominal view of the distal esophagus injury related to a Heller myotomy, and that's the endoscope going through the defect. This injury was able to be healed with 2 endovac changes. So looking at this data, we can see that it's safe and effective with closure rates that are comparable to what's reported in the literature. We've seen healing in a wide variety of injuries at all locations in the esophagus, as well as a wide age range. This helps us to understand the interval of changing, what types of injuries are best healed using this method, and we can present this information to the patients so they have better expectations on their care. This is our early experience with a limited case number. We have already added to this series and have had several other patients who have failed therapy, which kind of gives us more information on what type of injuries are not best managed using this. We also had no trauma-related injuries, maybe due to our low rates of penetrating trauma at our institution and limited follow-up. So we hope to develop more, have more cases over the next coming year, having a more variety of injuries in different locations. And our gastroenterology colleagues are also interested in starting to utilize this technique. So it'll be good to have that extra experience. Thank you.
Yeah, we have time for one question.
Chad Hall from Temple, Texas. Thank you for the presentation. I'm curious, I've only managed one patient with Endovac in the past 10 years, and it was kind of a painful process. So what is the advantage of Endovac versus stenting? Are you using Endovacs only? Or are you using it in conjunction with stenting or patient selection? And then how do you manage these patients nutritionally? Are they on TPN? Or are you doing surgical feeding tubes as well?
Yeah, great. Thank you. For our surgical patients on our thoracic surgery list, we manage these primarily with the Endovac. Some of our gastroenterology managed patients will have a stent placed. So that kind of allows us to have a opportunity for comparison. But as well as far as surgical patients, we've been managing all of them with Endovac. The vast majority of them are on TPN. There are a few patients who have a jejunostomy tube that is either placed previously or placed subsequently, but the vast majority are on TPN throughout this time.
Thank you.
Thank you. Next is Dr. Van Gent from, oh, sorry, you didn't get your clap. Dr. Van Gent from University of Texas is going to present on electrolyte derangements following emergent transfusion, an evaluation of 2,048 bleeding trauma patients.
Good morning, everybody. Thank you for the opportunity to present our work here. And thanks for picking this location. It's fantastic. I personally have no disclosures. So hypocalcemia and hyperkalemia are well-documented consequences of trauma and massive transfusions. But despite these severe traumatic injuries, these electrolyte abnormalities can be lethal just by themselves. Hyperkalemia is a well-known sequela from crush injuries and burns due to local tissue destruction and the nephrotoxic effects from myoglobin. It's well described after packed red cells and whole blood transfusions. But this may be due to blood storage issues, especially the age of the products, or hemolysis from rapid transfusion of these products. Hypocalcemia, on the other hand, is theorized to occur via several mechanisms, one of them being lactate binds ionized calcium in the acidotic state, and then intracellular influx secondary to ischemia or reperfusion. And then thirdly, the transfusion of citrate containing blood products, packed cells, FFP, platelets, and whole blood. In the hypothermic, hypotensive patient, the liver may not clear, this rapid transfusion of citrate. So further worsening hypocalcemia in these folks. With all that being said, little is known on how early a whole blood transfusion affects these electrolytes in the trauma patient. So we sought to identify the prevalence of hyperkalemia and the hypocalcemia with early whole blood resuscitation compared to component transfusions only. We began by acquiring a prospectively collected data set of all adult trauma patients that we consider 16 or older, who received emergency release products and were admitted between 2017 and 2021. These patients were divided into those receiving any whole blood transfusion and compared to those receiving only component therapy only in the form of packed red cells or plasma. Primary outcome was prevalence of hypocalcemia and hyperkalemia. Secondary outcomes were potassium-calcium ratio, which has been recently shown to be a predictor for early mortality and massive transfusion, need for hyperkalemia intervention and total calcium replacement in 24 hours. So we had a total of 2,048 patients, 1,240 in the whole blood group and 808 in the component therapy only group. The demographics were similar except for predominance of males in the whole blood group. This is because a chunk of our study period, we were only giving whole blood to, or we were not giving it to women of childbearing age. So higher amount of whole blood, of males in that group. The injury severity was certainly worse in the whole blood group, median ISS of 27 versus 22. The scene physiology and arrival physiology was worse in the whole blood group, also kind of denoting their severity of injury. Our pre-hospital transfusions and ED transfusions were similar between these groups, but by the 24-hour mark, the whole blood group did require slightly more platelets and more cryoprecipitate transfusions, again, for severity of injury. The ED labs and coagulation parameters on TEG were slightly worse than the whole blood group. And then the 4-hour and 24-hour electrolytes were similar between the two groups, but the whole blood group did have worsening AKI that started to normalize by about the 48-hour mark. And then additionally, there was slightly more calcium replacement in the whole blood group. So arrival potassium and AKI, unsurprisingly, were your predictors for hyperkalemia intervention on regression. And then injury severity and blood transfusions were the predictors for calcium replacement in the first 24 hours. And interesting, for each unit that you required in the first 4 hours, you had a 15% increase in likelihood of requiring calcium replacement. And then for mortality, no shockers here, but potassium-calcium ratio and injury and surrogates for injury were all predicted for 30-day mortality. So limitations for our study. First, our whole blood transfusions are usually less than 4 units, so we couldn't directly compare whole blood to component only because our whole blood group got a combination of both. There's also a cultural protocol for calcium replacement and not a true institutional protocol, so it may other centers may have different results. But in conclusion, our hyperkalemia occurs in a small portion of our, emergency release blood product patients. Whole blood transfusion did receive less hyperkalemia interventions. The calcium replacement was similar between groups. So I'm not sure if doesn't look like citrate amount between whole blood and components are a true driver for some of this hypocalcemia. And then transfusion volume appears to be the major driver along with injury severity. Similar to other studies, severe injury and elevated potassium calcium ratios continue to be the largest contributor for mortality. And for every 1 point increase in your calcium or your potassium calcium ratio, there's a 30% increase in mortality in patients receiving emergency release products. And further investigation is needed to see if whole blood is protective against these electrolyte derangements. Thank you for your guys' time.
We have time for one question.
Hey, Chad Hall again from Temple, Texas. I love this topic and have done some research on it as well. So thank you for a great presentation. I think your results are accurate, and the whole blood studies that are out there in hypocalcemia show that. I don't think the decreased citrate in whole blood, I don't think is as big of an effect as one would think. That's my question to you is, what is you showed like increased calcium or equal calcium replacement, but I didn't see a true incidence of severe hypocalcemia, or like what was the indication to give calcium? Was it given empirically? Severe hypocalcemia is usually an ICAL less than 0.9 if you look at previously published studies. And the other thing, about 30% of patients will arrive, like if you check their ICAL on arrival, about 30% will have severe hypocalcemia before transfusion. And so did you guys look at that? Or what is your timing of calcium monitoring?
Yeah, great questions. So we didn't look at the severity for our institution. We just used a cutoff of less than 1.05. That's like the normal range for us. But I can certainly look back and see who had an ionized calcium of less than 0.9. Like, that's a good point. And our timing is kind of variable. When our patients arrive, they typically are getting, their labs when they get their first IV. We don't always get an ABG, so they may be delayed on when we actually are seeing that. That being said, if we're going to the OR, they're getting an ABG with an ICAL immediately as soon as they hit the door, or if they hit the ICU. And if they're sick enough to, require an A-line, then they're going to get one pretty immediately. But yeah, that time is variable for sure. But yeah, lots of studies on, pre-hospital, even before transfusions, and whether or not that is crystalloid driven or injury driven. Definitely some hypocalcemia there. Thank you.
Okay, thank you. Our last speaker is Dr. Wendy Rockney from the University of California, Irvine. She'll talk to us about implementation and outcomes of a whole blood transfusion program at a level 1 trauma center. More on whole blood then. Thank you.
Good morning, and thank you for the opportunity to present our research here. We have no disclosures. So, not surprisingly, acute hemorrhage remains a leading cause of preventable death in the trauma patient. Perhaps more surprising is that while we think now of blood transfusion as mainstream, it hasn't been, except for probably the last about 100 years. So that started really with, in 1901, the identification of blood types A, B, and O, which kind of spurred the research and made it possible to actually do blood transfusions with a more predictable outcome. This was increased throughout World War I, where whole blood was transfused in military combat, and continued to spur research, which also helped with the development of component therapy by blood separation, which allowed us to give different components of blood rather than whole blood to every trauma patient or to patient who needed a transfusion. This continued to progress with research and implementation into practice until about the 1980s, where transfusion medicine, specifically component therapy, became more mainstream. And this has persisted. However, in the last 10 to 20 years, in the military arena specifically, military doctors have started using whole blood as transfusion for the acutely injured and hemorrhaging in combat. And what they've seen in these military arenas is improved outcomes with fairly robust data suggesting better outcomes with whole blood rather than component therapy. This hasn't completely translated the civilian world yet, but in the past several years, we've been taking this military data and trying to use it in our civilian population. There are some of the more obvious advantages of using like a cold storage whole blood for transfusion of the acutely ill trauma patient include things like a more rapid transfusion because you're not gathering separate components, decreased donor exposure as you have one donor rather than several, and whole blood loss. Basically in a trauma patient, you're losing whole blood, you're replacing whole blood with a theory that is closer to physiological normal. Based on this data and the emerging data from other institutions, our program instituted a cold storage whole blood program in 2020. Our current program consists of 2 units of whole blood, which we keep in a refrigerated section just outside of our trauma base. And we use this when acute trauma patients come in suspected of having major hemorrhage. This is at the discretion of the trauma team leader. Generally, is these 2 units are transfused followed by additional component therapy as necessary. This required obviously a multidisciplinary approach and cooperation, including the blood bank, the emergency room department, the trauma team, the lab, et cetera, et cetera. What we wanted to do with our study was to kind of analyze patient outcomes in this trauma population before we implemented this program and after, kind of get a bird's eye view of are we going in the right direction? Does our data agree with the current national data? How can we improve? How can we help other institutions institute this as well? So for methods, we designed a single center retrospective study at our level 1 trauma center. Our inclusion criteria were male patients 18 years or older who received transfusion within 24 hours of arriving to our hospital. Our time studied was between November of 2019 and April of 2022, which gave us a population of 257 for the study. We compared pre and post implementation outcomes and used for our data analysis, Mann-Whitney U as well as chi-square. So in our results, what we saw was that post-implementation, our trauma patients, although they had more comorbidities, they had fewer in-hospital complications. So as far as patients that had significant comorbidities, which we defined as things like MI, heart disease, pulmonary disease, anything that significantly influences patient outcomes, post-implementation, the incidence of these in our patients was 76% versus 61%, which was statistically significant. As far as in-hospital complications, this included anything that significantly impacted hospital course. So unplanned ICU admission, unplanned intubation, infection, et cetera. Post-implementation, 38% versus 54% before, again, statistically significant. We did note that overall, the hospital mortality between the two populations before and after was unchanged. They had similar ICU length of stays and similar days on the ventilator. And while not statistically significant, we did notice a trend towards lower transfusion requirements from component therapy after the implementation of this program, basically across the board. So recently, as this has become of more interest in the trauma, civilian trauma arena, there have been some bigger studies published looking at civilian trauma and whole blood. And what these studies have shown is that the addition of whole blood, in addition to these mass trauma protocols, mass transfusion protocols, improves survival both at the 24-hour mark and persistent at the 30-day mark, as well as fewer component therapy requirements. So when looking at our data and how this coincides with similarly published data, it is important to note that we kind of did this as an overall look at what we're doing and what we're implementing. So we didn't actually separate post implementation of our program, those who received cold storage whole blood and those did not, which probably accounts for why our trend towards fewer products and same hospital mortality was not statistically significant. Limitations of our study, including things like that there's plenty of room for further subgroup analysis, specifically in patients who received cold stored whole blood, those who didn't. And there's a potential selection bias due to the fact that those who receive cold stored whole blood is at the discretion of the trauma team leader, which means that some who qualified did not receive it and some who hopefully nobody who didn't qualify received it, but that's again, things we can do subgroup analysis for. And additionally, during the same time period that's studied, our institution has seen more implementation of further adjuncts such as Reboa and TXA. And those are things that we did not account for in this current study. But in conclusion, our initial overview analysis basically shows that we do have significantly improved outcomes in these patients after our implementation of a cold storage whole blood program. We'll use these results to support increasing the amount of cold storage whole blood available to our patients, as well as broadening the patient population that qualifies for this. And as I previously mentioned, a further starting point for subgroup analysis. And as to be understood, prospective data would be needed for further validation in the civilian population. Thank you for the opportunity to present, and I'm open to any questions at this time.
Thank you.
Thank you. That concludes our session. No time for questions. We will move on to scientific session 3. Thank you.
All right. Good morning, everybody. We worked on the sun coming out, but it didn't happen, but maybe today. I'll keep being optimistic. So I'd like to welcome everybody. It's Tuesday morning. We've had some really good discussions in the quick shots. We're excited that you're here. We hope you enjoyed your free time yesterday. Great day planned today. Lots of learning, lots of discussion. We're going to have research, obviously, an expert panel case discussion, and the Edgar J. Poth Memorial Lecture. I see we have our visiting dignitary, Dr. Eddie Cornwell is here. Round of applause.